Okay, everybody, and welcome back. Today is the last lecture we're going to do in this class. We've made it. It's the very end. It's really exciting. So we're going to talk today about treatment and therapy. So when we talk about therapy, what we're describing is psychotherapy. And so psychotherapy is just a blanket term used by all therapists to describe the many different types of treatments. And I think it's important to know we're going to look at several different individual treatment approaches. But when we talk about therapy today, most therapists are what are called eclectic. And eclectic means that they use a variety of techniques instead of specializing in just one. So I think that's important to note. Okay, so let's get into the meat of it. So the very first therapeutic approach was the psychoanalytical approach. And so this is what Freud's big contribution to the field of psychology is. He was the first person to think, well, maybe we could just talk about your problems and you'll feel better. But he had a couple of different ideas about how that would work. So the goal, the underlying assumption is that people have an unconscious mind, and our psychological disturbances are a result of like something that's happening in the unconscious. So so our problems are fueled by repressed impulses from childhood. The goal is to bring them to your conscious awareness so that you can then deal with them. Now, when we talk about Freud's approach, the psychoanalytical approach, usually that has to do with some sort of a conflict or Oedipal kind of thing, which modern psychotherapy has sort of gotten away from. But again, Freud's contributions, like if you think of therapy as like laying down on a couch while somebody writes on a notepad or something, that's because that was Freud. That's what his contribution was. What are some therapeutic techniques? So free association is one such therapeutic technique. Free association basically is you just have the patient just sort of like talk about anything, and they eventually will hit on some of their unconscious desires. So the therapist at this point is sort of guiding the client, or I should say the patient, because psychoanalysts, it's very medical because Freud was a doctor. And so eventually, like, insight may occur. So while you're doing this, this free association, you're just sort of like talking about whatever. The patient will experience resistance, and resistance is like they'll be talking, and then they'll bring up like an uncle, and they'll say, "Oh, I don't really want to talk about my uncle right now." The therapist sees this as the ego or the unconscious mind engaging in a defense mechanism. So the therapist will then say, let's talk more about your uncle, because like resistance is like a mental roadblock. Transference. So transference occurs when patients start to take their unresolved conflicts and feelings that they had, and they start to like put that on the therapist. So for the example I have here, you're treating the therapist like you might with your father, and so the therapist says, "So what do you see when you look at me right now? What are you thinking?" And so that's important. Also, sometimes in psychotherapy, because you are doing like years of intense therapy, and as we learned in the last unit, the mere exposure effect, sometimes patients start to develop feelings for their therapist. They see them as a friend, or sometimes have a romantic interest. But it's really important to maintain professional ethics and not, violate that by like engaging in any kind of inappropriate relationship with a patient. We talked about dream analysis already, but Freud, psychotherapy also really has dream analysis at heart as well. So Freud believed that your dreams were symbolic, and they were a window into your unconscious mind. And just kind of the key takeaway here is that they believe that therapists, psychoanalysts believe that dreams have two components. So the latent and the manifest content. So manifest content is like the actual what happened in your dream, and then the latent content is like what is suggested by this. Like what's the hidden, really underlying motive for this. Dream analysis is all about like explaining the latent content of dreams. And as I've told you, although dream analysis is fun, it's pretty much bogus. and that's psychotherapy. So now we're going to talk about the humanistic approach. So the humanistic approach kind of happened in direct contradiction to the psychoanalytical approach. The humanistic therapy is client-centered. And what I mean by that is the humanist views therapy as more of like a partnership versus, sort of like the therapist knows everything in psychoanalysis and then just sort of like tells the client everything. In this case, it's very much client driven instead of therapist driven. So it's really all about creating a non-judgmental environment, being empathetic, being genuine, demonstrating unconditional positive regard, which I'll define those in just a moment. So Carl Rogers is kind of the big founder of this. One of my favorite quotes is by Carl Rogers. Everything that irritates us about others can lead us to a greater understanding of ourselves. Okay, so basically the assumption here is that the patient or the client already has the resources they need. They simply lack unconditional positive regard, genuineness, acceptance, and empathy. So the goal is to help them reach their own conclusions about their difficulty. So positive regard is love, affection, and support of others. I think acceptance you probably already understand, genuine being the most true version of yourself. So one of the big assumptions is that that for people who are unhappy, we experience what's called conditional positive regard. I love you, I accept you if you act a certain way, if you behave a certain way, if you identify as a certain gender or a certain sexual orientation. And so people sometimes, because they're so afraid of like having that love, affection, acceptance like withdrawn, that they deny who they really are. So let's get more into this. The three core conditions to a therapeutic way of being. The first one is empathy. So empathy is, I kind of like this, seeing with the eyes of another, listening with the ears of another, and feeling with the heart of another. Unconditional positive regard, I kind of already talked about this, but an attitude of total acceptance of others despite their failings. This can be very difficult, by the way, like accepting yourself and accepting others unconditionally. It's something I've worked on for quite a while. And then genuineness, being your real, most authentic, most absolute, truest self, being completely honest with the client, and in hopes that they will be completely honest with you. So Roger says, saying you have empathy or unconditional positive regard is not enough. You actually have to feel them. And if you feel them, then you shouldn't be like, it should be apparent, like in your actions and in your words, instead of like, oh, I really care. Like people should sort of get that sense. And that's something that's hard to teach. Okay, so therapeutic methods. So as I kind of said before, clients are encouraged to freely find solutions to their problems instead of the therapist telling them what to do. So it's very much client-driven instead of therapist-driven. This image is, no direction. Oh my God. Okay, active listening. The therapist listens to the client and then restates what the client said in their own words. So they'll say something like, I hear you saying this. Is that correct? Because this shows the client that the therapist is paying attention to them, and also helps to clarify any like ambiguities and stuff like that. By the way, active listening isn't just a good therapeutic technique. It's a good like just communications technique. So I'm going to give you like a little bit of we'll probably pause this and I'll send you to like a PDF that goes more in depth with active listening. You can do that if you want or not, but it can make you a better friend, a better, spouse someday, or a partner in a relationship, and a better like son or daughter. So like, why wouldn't you want to do that? And then open-ended statements. So open-ended statements are a method of asking a question which allows them the freest response possible. Oh, I spelled freest wrong. Did I spell freest wrong? Freest. Is it 3E? I'm getting bogged down here. Okay. So closing question is like, did you like your meal? What color shirt are you wearing? Like, it gives you like a simple one or two word answer versus like open-ended questions. So tell me about that shirt. That's an interesting shirt. Because you're allowing them to really kind of open up. And that's the humanistic approach. So cognitive therapy is another important one. I would say probably the two most popular therapeutic approaches in modern times is cognitive and humanistic, or like some blending of these techniques with a little bit of behaviorism thrown in, which we'll talk about in a moment. So the cognitive approach assumes that all of our distress, all of our psychological problems have to do with aberrant or abnormal like mental processes, thinking. So the goal is to identify the irrational thoughts or the incorrect ways of thinking, challenge them, and replace them with more rational thought patterns. So cognitive emotive therapy was developed by a guy named Aaron Beck. And essentially, you're going to find that cognitive emotive therapy and rational emotive therapy are similar, but not quite the same. So Beck believed that clients have these ideas that they have are just hypotheses. They're not facts. We tend to think that they're facts, but they're not. So we challenge them with logic. So some examples, overgeneralization. So sometimes we overgeneralize people. We kind of paint everyone with the same brush, and you know, we say like all dogs are dangerous, or you know, all men are, I don't know, aggressive or something like that. So it's kind of like seeing the world in terms of generalizing. So I'll show you a video with examples of that. Polarized thinking. Polarized thinking is more of like we put people in either ors, right? You're either good or you're bad. You're right or you're wrong. You're smart or you're stupid. There's no like middle ground. This is really common in athletes, right? If you're not first, you're last. That's right. So which isn't actually true, but it can really cause, because what happens when you don't come in first? Well, it can lead to all sorts of self-loathing and anxiety and sadness and all kinds of other things, not just for athletes, like in a broader sense. Selective attention. We only focus on one detail out of many. So like if you had I don't know, you performed in a play or something like that, and one tiny little detail went wrong, you'll focus on that detail and not all of the other things that went right in the play. Now let's talk about rational emotive therapy. So rational emotive therapy is just, it assumes people are rational and emotional problems are the result of unrealistic assumptions about ourselves and others. Okay, so here are common irrational thoughts. You don't need to know these, but I just think it helps to sort of illustrate this point. My unhappiness is not my fault. People and events over which I have no control are responsible. So that's more of like an external locus of control. My happiness is not my responsibility. It's, you know, my horoscope, or it's my parents, or it's my my job, or it's this. It's not anything related to what you've done. I have to be approved and loved by everybody. I have to be totally in control. When things don't go my way, it's a catastrophe. These are just some examples. Okay, so the meat of this theory is it's called the ABCs of rational emotive therapy. And so basically what you have is an activating event, which leads to a belief about the event, which leads to a cause about the event. And essentially what we're saying, what Beck has said is that we tend to think that the activating event leads to the consequence, right? So like, here, let me give you an example. Okay, so activating event is something sucky that happened to you. So someone called you a jerk or something like that. This leads to your belief about the event. So your belief is like, oh, he said I'm a jerk and I have to be loved by everyone. And why doesn't he get that? So like, that's your belief, which leads to the consequence. You know, you feel sad or you get angry or something like that. So it's not the event. It's not A that causes C. It's actually the belief that causes the thing. So that's the goal. So what we need to do is identify these irrational beliefs people have and like kind of change that thought pattern. So again, I just kind of said this, but the activating event does not cause the consequence. Our belief causes the consequence. So we got to challenge and change this belief. Ways that you can do this. I'm not really going to ask you about all the different therapeutic techniques, so I'm just going to kind of go through these relatively quickly. Disconfirmation. So you directly, like, you have the client directly, like, you contradict what they're saying. Reconceptualization. So finding a way to sort of like reshape the idea into a more healthy pattern. Insight. Insight is just that aha moment. The light bulb goes off and you're like, oh, I believe that everyone has to like everything that I do. And that's why I get so upset when they don't like like that's the aha moment that people have. Role playing. So sometimes like role playing can happen in a lot of different ways. Sometimes it might be the therapist that's like, okay, let's go back to that situation that really bothered you, and you be the jerky person and I'll be you. Or, you know, they might say, okay, like, let's pretend like you could go back and like, what would you say this time around? So that's role play. Modeling. So sometimes the therapist will just model, okay, here's what I would do in that situation. And then persuasion. And I think to a certain extent, I don't want to overgeneralize too much, but I think sometimes like effective therapy is persuasion, but it's subtle persuasion, not just saying like, you're dumb, stop doing this. It's more of like a subtle a way of changing a person's mind. Okay, so we've talked about how you feel. We've talked about your unconscious mind. We've talked about how you think. Now we're going to talk about what you do. So the behavioral approach is changing behaviors through using conditioning techniques, classical and operant conditioning techniques. So the assumption, self-awareness, insight's not enough to make your problems go away. Problems and emotion have been learned through patterns over time. So we have to unlearn them through classical and operant conditioning. So treatment is to teach more effective behaviors, not effective thoughts, through classical and operant conditioning. So a couple of different ways you can do this. Systematic desensitization is one. And in systematic desensitization, it's a really fancy way of saying something very simple. You teach a patient, and this is like with phobias and things like that. You teach a patient relaxation techniques, maybe breathing, something like that. And then gradually you expose them to the stimulus that they're afraid of. So if it's like spiders or something, the first time it might be like, okay, I just want you to think about a spider. Now relax, breathe. The next time it might be, okay, now I want you to look at this picture of a spider, and then now I want you to, and then you relax, and then now I want you to see this toy spider, and then eventually getting up to the point where you can see a live spider, maybe even holding a spider. So it's gradually exposing you to what you're afraid of, and trying to get you to relax. So you're changing the emotion. It's kind of like it's a combination of classical and operant conditioning. So I've got a video I'll show you there in just a second. Counter conditioning. So counter conditioning is pairing something you don't like with something you do like. Like maybe you're afraid of going, I don't know, you hate going to the store with your parents. So your parents, when you go to the store with them, they buy you a treat or something like that. That's counter conditioning. Aversive conditioning. So aversive conditioning is replacing a positive response to a harmful stimulus with a negative response. So like, for example, giving someone like Ipecac or something that makes your stomach kind of retch a little bit and puts it in knots, putting it in alcohol so that you start to associate alcohol with getting sick. Or like aversive conditioning was used before homosexuality was removed from the DSM. This was a technique to remove homosexual behavior. So same idea, you would give them something nausea inducing and then expose them to like erotic materials so that they started to pair the feelings of ennui, like the horniness feelings with feeling sick. So when they got into those situations, it would make them retch and feel sick as well. This technique was banned in by the psychological community in like the 1970s. So this is no longer done by psychologists. It is still used sometimes in some of those camps that they'll send homosexual teenagers to. But yeah, it's been banned by the psychological community as a whole. Flooding. So you've seen flooding before. When I showed you the video of the pickle phobia and the mustard phobia, where Maury Povich was like showing them or like making them directly confront their fear. The goal here is like a massive exposure shows them that it's not as bad as they thought, and then you can sort of work back from there. So I mean, I do agree that that video was just using people's phobias for entertainment purposes, and maybe they didn't even have real phobias. But although it seemed intentionally cruel, like there was a reason why they did that on the show. Well, actually, probably a couple of reasons. Modeling. So we've already talked about modeling. So this would be more of like an observational learning technique. And that's it for the behavioral approaches. Other approaches, and none of these are going to be on a test or a quiz or anything, but I just kind of want to hit these relatively quickly too. So there's existential analysis, and this is trying to find, like a lot of times people have, like if you have depression, it's for existential reasons. Like you're thinking about like mortality, or does any of this have any meaning? Where am I going? What am I doing? These sort of like big questions, like what does it matter? So existential analysis was proposed by, I'm blanking on his name, Viktor Frankl. He wrote a book, it's a short read and it's really, really good. I highly recommend checking it out. It's called Man's Search for Meaning. He was a Holocaust survivor, and the first part of the book is him talking about just the cycle. I've never read such a it just really gets into like the mental state and how they broke down broke down Jewish people and like mentally in concentration camps. And then the second half of the book is him talking about like, well, so why am I not depressed? Why this? And so that's Man's Search for Meaning. A great book, worth checking out. Gestalt therapy. So Gestalt therapy is focusing on how one feels instead of why one feels. And so one of the techniques is called the empty chair technique, where like the therapist literally takes an empty chair, sits it in front of the person, and then has them talk to like the empty chair, like talk to themselves as if they were in the empty chair or something like that. That's Gestalt therapy. Group therapy, we've talked about this a lot. We talked about this with PTSD. So self-help groups, AA, NA, family counseling, it's just basically therapy that happens with more than one person. And then touch therapy. So this one is, it's like an energy therapy, which is supposed to help reduce anxiety. The therapist places a hand near a patient and detects and manipulates the patient's energy field. This one I'm less, I'm more skeptical of, I'll say it that way. Okay, so the last approach is the biomedical approach. So the biomedical approach assumes that if we intervene in the brain and the body, we can affect mood disorders and behaviors. So the first one is psychosurgery. Psychosurgery so psycho means mind, so it's surgery on the mind. And psychosurgery, probably the most common one, is the lobotomy. If you watched the history of mental illness, you may have heard about Walter Freeman. If not, I'm going to go ahead and put the link in here for you to learn about him. He pioneered a treatment called the transorbital lobotomy, which basically, before lobotomy was a major surgical intervention, like you had to be put under, you were in the hospital for a while. A transorbital lobotomy could be done in about 5 minutes. So we'll check that out right now. Shock therapy. Shock therapy is still performed today, but it's known as electrocardiogram therapy. So it's running an electric current into the brain, which causes a seizure to happen, which for many people improves their symptoms. So it's electroconvulsive therapy, formerly known as electroshock therapy. So you run an electric current to the brain, you create a seizure. It's used as a treatment for schizophrenia, depression, bipolar disorder, sometimes obsessive compulsive disorder, but it's really, I think most commonly depression and bipolar. And the thinking here is that, or they're not 100% sure why it works, but one theory is that it boosts what's called neurogenesis, which is having this neurons form new patterns. patterns, essentially. So it's like resetting your neurons. So here's a video we'll watch. Actually, I kind of wanted to go back to this. So I want to show you what modern therapy, what it looks like now. You'll see this in the video, but essentially the patient is, they really monitor everything. It's not like they just hook some electrodes up to your head and then they shock you. You're usually given some sort of a muscle relaxant so that the spasms don't get, like the spasms from the seizures don't, aren't too damaging. You'll see here they've got, you're hooked up to an EEG, so they're looking at your brainwave pattern. You're looking at an ECG, which measures your heart rate because they don't want to give you a heart attack, and then an EMG, which measures muscle activity. So they're measuring your blood pressure. EMG goes to like on the foot here. And don't worry about all these acronyms. I'm not going to ask you about them. I just want you to kind of understand. So they're measuring your blood pressure, checking to make sure blood oxygen levels are good, and then they'll have some sort of a intravenous line for muscle relaxant. Then they run the electric current into the brain. I would also say probably the one side effect of this is memory loss. For most people, memory loss is temporary. It doesn't last too long. There are like extreme cases where people have like the memory loss is more severe, but that tends to be when ECT was done like previously, like where it was just sort of like guesswork, I guess. Okay, so transcranial magnetic stimulation is another one. So we talked about this in the bio unit, but it's essentially you use a magnet to interrupt the firing of neurons. So we watched the video where the guy, where they interrupted his motor cortex and he couldn't, take a drink or write his name or something like that. What they do, basically how it works is you take the magnet and they're able to target areas in the limbic system, which is associated with depression. So they interrupt these and kind of the same thing. It forms new neural connections. One of the benefits of this technique is that it's non-invasive. It doesn't have any real bad side effects. So you can go into your therapist, they can do this, and you're out at, it's a pretty quick procedure. And this is relatively new. There are also invasive forms where they can put in electrodes into your brain. So that would be the video of the guy who played the violin, and then they created sort of a thing he could turn on and off so that his tremors would stop. Same idea, but used for mood disorders. And then the last thing is psychopharmacology or drug therapy. So the idea here is we're going to study drugs and what effect they have on behavior, mood, and the mind. So there are 4 classes of drugs. The first one we're going to talk about is antipsychotics. Antipsychotics are used primarily to treat schizophrenia. And there's lots of different, this is why basically lobotomy stopped happening, is because we got better with pharmacological and pharmacological studies, not studies. We got better at making drugs. That's what I'm trying to say. So the way it works is it blocks dopamine receptors. If you remember, schizophrenia, one of the causes of schizophrenia or assumptions is that there are too many dopamine receptors, and this is what causes the hallucinations and delusions. So they do work. Long-term use of antipsychotics, however, can produce something called tardive dyskinesia. And it's sort of like Parkinson's-like syndrome symptoms. So facial tics or muscle movements. So we're going to watch a video that will show you some examples of this. You don't need to watch the whole thing, but if you just want to kind of see, you can kind of skip around in the video. Antidepressants. So antidepressants we've talked the most about. They improve mood and anxiety by increasing levels of serotonin. So remember, they're synthetic serotonin reuptake inhibitors. So what we're looking at here, here's the presynapse or the terminal, and then this is the dendrite of another neuron. So we allow serotonin to stay in the synapse and prevent it from reuptake from happening. So we prevent it from getting reabsorbed. So eventually more there will be more activation at the dendrites, and then you get more serotonin, and it boosts mood and well-being. Mood stabilizers. These are used to even out the highs and lows of bipolar disorder. The most commonly used one is lithium. So it doesn't prevent you from having depression or mania, but it just sort of like, it stabilizes the teeter-totter, if you want to think of it that way. And the last one is anti-anxiety medication. So it produces relaxation by lowering sympathetic activity in the brain. There's lots of different ways anxiety medications work. Sometimes they boost the production of the neurotransmitter GABA, which is an inhibitory transmitter. Sometimes it lowers levels of norepinephrine or something like that. Examples of Xanax, Valium, and Ativan. It's important to note that because this slows down, because an anti-anxiety medication is essentially a depressant. And when I say depressant, I don't mean it makes you depressed. I mean it slows down your nervous system. So when people take anxiety medications and alcohol is also a depressant, and it can slow your body down to the point where you die. And that's what's happened with, as the use of Xanax recreationally has gone up, you've noticed many very popular people who have died because of their blending this sort of like cocktail of, Xanax and alcohol and, marijuana and stuff like that. And that's a great way to end everything, right? And that, ladies and gentlemen, is psychotherapy. If you have any questions, please let me know. Otherwise, it's been a pleasure being your teacher. Take care.